Okay, so hello everyone. Today at the On Your Future seminar, we will be having Dr. Eva Peper with us, and she will be presenting on advanced MRI techniques for the characterization of cardiovascular blood flow. And yeah, as you can see, she's from the University Hospital of Bern and the University of Bern. And yeah, I'm excited to see what you can share with us.
Yeah, thank you very much for this kind introduction. Yeah, I'm happy to present today a little bit about my work and also my background on 4D flow techniques. So let me just advance the slide. Yeah, as we already said, I've been working on 4D flow for a while. So I did my PhD in Amsterdam in the Netherlands. And I mostly did like velocity measurements in the carotid artery, in the aorta, and in the brain there. So I did this kind of nice images that you see here on the right, which is just like one of these 4D flow visualizations of the carotid artery, which I will talk about today, how you can get there. And then I moved to Switzerland, where I also kind of continued working on 4D flow, but then more in the direction of turbulence measurements, which could be done by like a similar technique. So I will also quickly talk about that. So currently I'm working in Bern, and I switched a little bit of topics. So now I'm working more on like quantitative imaging, but still some kind of cardiac MRI imaging. So it's not so far off. I must say I'm a physicist, so most of the time when I develop techniques, I scan bottles or phantoms. Sometimes I then move on to scan a colleague, but I do not have so many patients that I've scanned. I usually collaborate with clinicians on that. So I do have a few. So I once scanned a group of familial hypercholesterolemia patients, aortic valve stenosis patients. I once had a congenital heart disease patient, and another one who had like aortic stent. So I'll talk about this throughout the talk, but I'll show like an example of this last one in our kind of second half of the talk. So just a very brief overview of cardiovascular imaging modalities that I actually not work with. So I just do MRI. I work on this MRI techniques. I do not like work with CT ultrasound, but like, I mean, it's still interesting for this talk to be aware that they exist, of course, as you probably know. So we have CT to kind of image, for example, ischemic or hemorrhagic strokes, and intracerebral hemorrhages. We have ultrasound, in which we can estimate, for example, the intima media thickness, which is correlated a lot with the risk of cardiovascular events. And it's also interesting if you want to look at atherosclerosis, plaque, or a stroke. We do have, of course, Doppler ultrasound, in which we can also estimate the blood flow velocities and regurgitations, which is particularly interesting in valvular or heart disease. We have catheterization, in which we can make angiograms or measure pressure gradients, for example, in the coronary arteries. Yeah, so these are great techniques and very useful. But what I will be talking about throughout this talk is really just MRI techniques. So with MRI, I think the most important thing for cardiac MRI is really like the anatomical imaging that we get from it. So we can very nicely see the heart chambers, as you see in this view, and the valves, but you can also see like small vessel, like the coronary arteries, for example, in that view. You can measure scarred tissue. So for example, with this late gadolinium enhancement technique, in which you see the scar here in the myocardial wall, but you can also see that very well in these quantitative mapping approaches in which you measure these T1 and T2 relaxation times of MRI, and that are then characteristic for some certain behavior. You can measure very nicely also the vessel wall composition, so you can actually get like here, for example, the carotid wall very much detail, and you can see like thickening of the carotid wall and plaque development. So it's also very interesting. And what we'll be looking at today, so we can get, of course, perfusion maps of the heart, but we can also measure flow. So this is actually this very last image in which you see actually aortic an aorta, and you see blood flowing with a certain velocity through that. So that's like the main part of this overall topic that we will be looking at today. This flow MRI for cardiovascular imaging is particularly interesting. If you, for example, look at like complex flow patterns, as you can see in, for example, congenital heart disease patients, in which patients have like a very complex anatomy already. So it's very hard also with Doppler ultrasound to see a certain velocities at certain positions. And yeah, with flow or 4D flow, you can actually visualize that at least very nicely. And then from that acquisition, you typically try to estimate, let's say, the standard parameters like peak velocities or flow or ejection fractions. So what you see here is like this 4D flow visualization. You see a 2D plane going through it, at which you can, for example, here measure also the flow curve or the velocity curves over time at a certain position along your aorta. But there's more to flow imaging. So you can, from this measured velocity, you can derive a lot of other parameters. So one very famous one is wall shear stress. That also exists in different components, like oscillatory wall shear stress, etc. There's something like pulse wave velocity or turbulent kinetic energy when it comes to turbulences. But this is just a few. So this is just the ones that I will mention today, but there is even more information that you can retrieve from this type of data. So this is just the overview of what I will be talking about today. So I will give you an introduction into flow MRI. Maybe you already know how it works, then this is maybe a little bit too much, but for the rest, I will then also show you what, with this data, we can derive like wall shear stress, pulse wave velocity, and also turbulence. And then in the end, I will show you one 4D flow MRI case, which I was asked to do. So I was asked to do the scan because, yeah, it was just a patient for who that was very interesting. Yeah, so let's start with flow MRI. So if we want to do 4D flow, basically, so not just like 2D, then 4D flow, the name is a bit confusing, but 4D flow refers to flow measurements in 3D. So you do not have, let me get a pointer, 1 second, there's a pointer. So you do not have, you do not select just a 2D slice, you actually select a 3D volume. That means that if you want to acquire this 3D volume throughout your scan, you have to, as with every MRI scan, actually, you have to acquire it like voxel by voxel by voxel by voxel. So like imaging point by imaging point by imaging. It's not like a photo as we have in CT. So if we want to acquire like one single imaging point for now, yeah, I'll just show some basic MRI stuff, but not in too much detail. You will acquire like this single data point, first of all, by applying this radio frequency pulses that you have with MRI. So you apply that, and you will then consecutively detect a signal of this relaxation process that is happening afterwards. So far, so good. That's like very basic MRI imaging. To do this in 3D, you also want to know the location of your acquisition. So you have to apply these so-called gradients, which are just basically additional magnetic fields that are kind of controlled by a current that you apply. But that additional gradients, they just give you the location where you're at of your 3D volume. So by applying these 3 gradients, I know, okay, I'm at this location. And this acquisition for this one data point takes, let's say, 3 milliseconds. That means that, let's say, this whole image, if we have, let's say, 100 by 200 data points in this plane here, let's say, takes around 60 seconds. So that's like one 3D image, not a flow image. If we now want to make this a flow MRI image, what we do is we take this basic 3D sequence part, and we add another gradient, which is flow encoding gradient. And we repeat the scan, but now with the inverse gradient of the one that we acquired. The strength of this gradient here that we apply is actually defined by the Wenck. So you might have heard about that if you've ever done a flow scan. So this kind of defines how strong you actually encode for a velocity that is happening in your image. Okay, so far so good. We have, let's say, an additional gradient in this Z direction. That means we are doing flow encoding in the Z direction, and we have 2 images. So now our scan is already 2 times as long. And I have to mention another concept that is related to that, and that is, if we now acquire this image, we will get a magnitude of our image. That's like where you already see, oh, there's the aorta. But since our data as it comes out of, let's say, out of the scanner is actually complex, so it's like a complex number, it not only has a magnitude image, it also has a phase image. So that's just a concept, right? Like a mathematical concept. You have, this is the same data set, it's the exact same data, it's just the magnitude component and the phase component of the data. And of course, we have that also for this second data set that we acquired with the opposing velocity gradient. So we have magnitude and phase, magnitude and phase. And the concept of flow MRI is basically that we have 2 phase images, so with different flow encoding gradients that we have acquired in 3D, and we now subtract them from each other, and we will actually get out of that, we will get a velocity map. So that's a nice, beautiful concept, I think, because actually the grayscales here in this image are directly related to the velocity. So that means, let's say our Z gradient was, the Z direction was now here going up and down. It is also our velocity encoding direction. So that means every particle that has moved throughout your Z direction or in the upward direction will be encoded in white, and everything that was moving downward will be encoded in black. Both just mean there will be a positive or negative velocity. So this is, let's say, already the basic concept of flow MRI or flow encoding MRI. You now want to not only encode your image in, let's say, the upward and downward movement, you also want to encode in your image a left and right movement, and you want to encode in your image a like backward and forward movement of a certain particle in your body. So that means that actually the procedure that we just had, we have to repeat, basically 3 times. But since we have this always like a reference image that we can share between these acquisitions, actually we share it, like we have to repeat the scan 4 times. So that's a 4D flow basically. With this, we have encoded the velocity in all 3 directions. There is one remaining problem, and that is, of course, that we have to capture, or we want to capture this this encoding, and we want to capture the velocity of each particle for each cardiac frame, like for each cardiac movement, so to say. So otherwise it would just be a static image, which will probably not tell us much. So that means what we do is, let's say, every point of our image, we also want to acquire at every time point of our heartbeat. So we apply ECG, we acquire the ECG alongside our scan. And then once we have the data acquired, we say, oh, now let's take all, let's say, systolic data points. That would be, right? That would be like all data points that just happened after our heart peak. And then we say, okay, and now let's take all diastolic data points. That would be all data points that are like towards the end of our ECG signal. And then after the scan, we just like sort our data into these two kind of data buckets, let's say. And we could now reconstruct an image that has just systolic data points in there, and we could reconstruct another image which just has diastolic data points in there. So by this, we already did, let's say, a cardiac binning, and we could reconstruct an image in this or the other state, but it's still quite coarse, right? We want to have more data points, so we typically do not just do systole and diastole. We actually do more steps. So let's say 15 cardiac frames, but just with the same principle, and we can actually reconstruct an image in which we see 15 different points along the cardiac cycle. It's not like a real heartbeat, it's like a merged heartbeats of all heartbeats together. It represents like one average heartbeat, which is looping throughout, in this one, like this video animation. But yeah, you already see the problem, like in order to get all the data in here, you need to acquire just the scan also then 15 times longer. So it was already like 4 minutes, and now we have to make 4 minutes times 15, and you end up at like very long scan time. So for this reason, most of these flow scans also apply some acceleration techniques that makes them just a little bit faster. But they are known to be very long scans, simply. So yeah, this is what we get. We then have a velocity map for each direction, but the velocity map is not also time resolved. Of course, we still have the magnitude information that's not lost. That's also time resolved. So here we see the heartbeat. What I will not show, but which is also a problem, is of course breathing motion. So usually you don't do that only for cardiac motion, this binning, but you also do the binning for the breathing motion, which typically makes the scan even longer. But I will keep it out for now. It's just the same principle, but then for another motion type. Yeah, so how do we get to this beautiful animated images with all this colorful details? And that is, we just take our velocity maps that we now have, right? We have them in 3D and we have them time resolved. And we look at each data point. And then each data point, of course, has like a velocity component in X, in Y, and in Z direction. So if I combine these velocity components, I will get a vector which represents the direction of my flow or of my movement. And the length of the vector also gives me information about the strength, so about the velocity actually of my motion. So that's why we use this direction of the vector, but we also usually use some color coding, which gives us, let's say, the length of the vector. So it tells us like how fast were we actually moving in that direction. And that's what you see typically in these plots, is just, the color stands for the velocity value. In order to get these flowing movements, movies, there is typically two methods that you do. So there's either streamlines. So that means that you look at this grid that you just acquired of voxels at one time point, let's say. You can, of course, repeat that for any other time point, but let's say for now, an instantaneous time point. And you then look at like a like a line that would represent like a tangent to each of these vectors. So by that, you would already estimate, oh, okay, that's like where my blood is flowing in this direction. And there's another one that's called path lines, and that is that you rather say, okay, I look at this particular voxel, and I look at it for different time points, and I check like what this voxel actually, which path that voxel would actually take throughout the scan. So I try to estimate that more like on a time-based method. So it's just different visualization techniques. Yeah, so that's let's say the final result after reconstruction. What you see here is an aorta. You see it time resolved. You see it color coded. You see here, to be honest, I'm not sure if it's like streamlines or path lines, but you see it's like a visualization of this flow. And this is, of course, very nice and very, I don't know, information-rich images that you can look at. In the end, from this data, ideally, you can derive all the parameters that you want to know at every location that you want to know. So you might want to know, I don't know, peak velocity right after the aortic valve, or you want to know the helicity, or you want to know regurgitant flow, whatever. Yeah, so it's still complex to analyze also this data, but still, in principle, it has all that information. Yeah, so that's, for example, what the flow curve would look like, derived from 40 flow MRI, showing the net flow over time for ascending and descending aorta. When we do this data, I mean, it's not like, well, if we acquire the data, a lot of time we do, or what I, for example, I did reconstruct the data on my own using MATLAB or whatever reconstruction tool I had. So this was like my part. But when it comes to visualization and like doing all this analysis, a lot of times I just used some software that was available. If it's very complex, if the data was very complex. And that's what like many people do. So there's a lot of softwares. I mean, I just try to remember a few, but probably there's even more by now, in which you just load your 40 flow data. You can see it there. So typically you see like here the magnitude image, you see your 3 velocity encoded images. You have a step in which you can do a segmentation. So that means a delineation, in this case, of, let's say, your aortic region. And then you have options in which you can do this path line tracking or streamline tracking. You can draw like RIs in this image and do some quantification there. I would say it's still quite complex, of course, for clinical use, because it has so many possibilities. So, but it's of course interesting, like for special cases or complex anatomies. Yeah, so that's the part just on how do we acquire this 40 flow MRI data. I just now want to mention a few parameters that you can derive from the data once you have acquired it. So one famous one is called wall shear stress, and that is basically the tangential force on the vessel wall that can be derived from the velocity field itself. And I mean, you can, for example, I saw a nice example once. It's also what you see in riverbeds, for example. If a river has a strong current or like a less strong current, you will see it also in how the riverbed will behave. And of course, that's also what you will see on the endothelial cells of your vessels. So typically, a high wall shear stress is perceived as something good. The vessels like having like a undisturbed, steady flow. But once the velocity and the flow is somewhat disturbed, also the endothelial cells start to rearrange and not be like in line anymore, which can lead or be the start of any type of inflammation. And it is also, of course, if, for example, there is some oscillatory or so like behavior of this motion, which is just not what is, let's say, good for the endothelial cells. So there is, this theory that like this, let's say, like a low wall shear stress comes first, and then comes vessel wall thickening, for example, or inflammation, or atherosclerosis. I think it's still part of like investigation, these things, but still people are very, very interested in regions of low wall shear stress, as this might kind of be an early indicator for atherosclerotic plaques, for example, or just changes. So when you take your, once you have your velocity map, you can here, for example, in the middle, you can just plot your velocity profile through your vessel. So this is just a simulation, right? Your vessel wall is this red circle, and you have velocity going through, which is highest in the center and decreasing to the outer part, just this parabolic shape that you would expect. Then you can derive actually the wall shear stress just by the derivative of your velocity component in one direction by the kind of inwards pointing normal on your vessel surface, which is in this case the Z direction, let's say. And that would already be a little bit inaccurate, because you just, I mean, if you look at this voxel, I mean, you just don't know so accurately where is your vessel wall. You don't know so accurately like what is your exact velocity there. So you already have to make like a parabolic fit in order to get somewhat close to the actual wall shear stress. But this is still like a debate, and it's still a thing that is just debatable on how accurate wall shear stress is, because you don't know like so accurately your vessel wall and your velocity exactly at the vessel wall. But of course you can interpolate, and you will get a result. So that's just what I mentioned. And so these are just some results of, for example, here a wall shear stress in the aorta plotted here, where you have a healthy control, and you have an aortic stenosis. So you will have high velocities, which in turn will create a high wall shear stress here at the wall, whatever that means for now. Or for example, here for patients with a bicuspid aortic valve, also the wall shear stress pattern will change. So if you also look at, let's say, the different orientations of the aorta, what that means. And typically what is interesting here, I mean, you see changes, let's say, of high wall shear stress, which, I'm actually not sure if that will directly lead to some remodeling, but certainly like regions of low wall shear stress will lead to some remodeling at some point. So it's interesting to kind of investigate that further and in larger studies, what that actually means. But that is, let's say, the concept of wall shear stress and why you're interested in it. Second. Briefly to pulse wave velocity. That is another biomarker that's actually indicating the vessel stiffness, which can be, again, a sign of like stiffening. Of course, if a low wall shear stress, a high pulse wave velocity can be a sign of stiffening of the artery and plaque formation. And also like stiffening correlates with age. So what is typically done is this global pulse wave velocity measurements, which are done with an ultrasound probe at the common carotid artery and the femoral artery. So you will see a flow curve or a pressure curve at the carotid artery and at this femoral artery, and they will have a time delay. And that is because the vessel itself has a certain elasticity. So if the vessel would be 100% rigid, then these two curves would be like instantaneous, or not instantaneous, but let's say with the speed of sound, at least they would arrive at both locations at the same time. But because the vessel is elastic, there will be some energy loss, and actually there will be a small delay. So the stiffer the vessel, the shorter this delay will be. And that's actually what you measure. So in order to estimate post-wave velocity, you simply divide the distance between the two measurement points by the time delay that you measured between the curves. And that is with this Moons-Korteweg equation. It's actually related to the elastic modulus of your vessel. I mean, there's some assumptions to it. Maybe it's not correct in all cases, but still that's the typical relation. And that can be done also with flow MRI. So if you have a 2D or 4D flow image, and you, for example, take a slice here through the aorta, which you have the ascending and the descending aorta, then you see the ascending part is here, the bright one, the descending part is this black one. Just saying here, like it's upward and downward velocity. And then you can plot the velocity for these two circles. And you will see there is a slight delay actually between the two velocity curves. And that delay is just the same delay that you measure also with global post-wave velocity. I mean, you have to estimate the distance is now here, just the distance that the blood has traveled through the aortic arch. And the time difference is just the time difference at the foot here between these two flow curves. We have done this once in a study on actually carotid arteries. So we had actually 2D flow measurement, which is just the same principle, but then in slices, in which you select a slice here at the common carotid artery and like one slice at the internal, at the level after the bifurcation in the internal carotid artery. You can derive the flow curve for these two locations, and you will see there is a small time shift between these two flow curves, which is again related to post-wave velocity if you take into account the distance between the slices. And we could see if we plot here the post-wave velocity against the age of our participants, we had some elderly, some younger patient, healthy volunteers actually. You see there is a strong correlation between age and post-wave velocity. Yeah, so that's actually quite interesting. But I must say, post-wave velocity is very sensitive to any type of physiological changes also throughout the scan. So it's, I think on like a large scale level it works, but if you want to detect very tiny differences, it was always very challenging. Yeah, so the last thing I want to mention that I've also been working on is actually turbulence. So, so if you have just a regular vessel, you will have a laminar flow with this parabolic flow profile. However, if there is a narrowing, you will have very fast velocities at the narrowing, and behind it, you will have a turbulent flow. So that is like the case if you, for example, have aortic valve stenosis, because just, yeah, the more severe the stenosis, the smaller like the region will be in which blood can go through. So there's two theories. Like one is like turbulence actually dissipates energy, and then that means like the heart has to actually pump stronger in order to maintain like the same, or like with the same energy, so to say, bring the blood to the system. But also there is a like argument that this turbulent flow shear forces can actually, because of this high velocity, damage blood cells itself. So it's interesting to look at like turbulent regions anyway. So what we looked at so far is just laminar flow. So we had like one mean velocity that we encoded in our image. But what actually happens if we have a turbulence, then we will have a stochastic motion in addition to our mean flow. And that will actually, so if we kind of take this apart, we'll have like some mean velocities that we already encoded in our 4D flow scan using the Venk. but we will also have some stochastic motion. And that is actually something that will disturb or decrease not the phase of our signal, but the magnitude of our MRI signal. So it will affect the magnitude of our MRI scan. In the end, you can look at this images also in like a certain velocity probability distribution. So you will have like some mean value, and you will have a standard deviation, that kind of your velocities that stand for the turbulence that you actually measure. So if we now, for example, increase our encoding strength, so it's a bit unintuitive, but it means that you have a lower bank, then it means that like at regions, so here, for example, this is a region right after the aortic valve, in which we would observe turbulences, that this region, these regions, first of all, have a signal loss because of the turbulence, and this will become stronger if you have a higher encoding strength. So that means that we can actually encode also the turbulence in, or the strength of, or the turbulence, we can encode the turbulence in our signal itself. And that's what you can measure. So you can also measure with different velocity encoding strength the magnitudes now of the image. You can refer to a reference image, and then you can estimate actually this standard deviation that is created by your turbulence. And if you now take the standard deviation of your velocities in all three directions, that's a value that you call turbulent kinetic energy. That's just something that you can derive. This is something that a former colleague of mine has looked at. He had looked into this standard deviation of our velocity for healthy controls and for patients with a aortic stenosis. And you see that throughout the cardiac cycle, the standard deviation of the velocity was much higher for aortic stenosis patients than it was for healthy control. And that's also what you see here. They had I think some valve prosthetic in there, but you also see here that the turbulent kinetic energy in turn, so that's just the three-dimensional value, was higher in the patients than it was in the healthy controls. And this is actually a scan that I did when I was working on these topics. And that is what you see, the magnitude image, and now time resolved overlaid the turbulent kinetic energy value that we can calculate. And you see that in this aortic valve stenosis patient, you see that, of course, also with the heartbeat, the turbulence values kind of increase and then decrease again. And if you look at it close, you will see that, of course, these high turbulent kinetic energy values are in the region where you will also have high velocities, because you have of course, a stenosis, so also high velocities at the same time. And this is also similar to something that has been published before, in which you have high velocity values after stenosis and high turbulent kinetic energy values there. So that's it from, I think I could talk even more about like also other aspects of a 4D flow, but I don't want to make it too long. So if there's some discussion point, we can always discuss this afterwards. I now just want to give you just an example of a 4D flow case in which I scanned a patient, and that was not like a scan that I did for a study or for, it was more like, this was a patient that some clinician asked me to do because they couldn't really tell from ultrasound what was going on. So it was interesting to actually do that with 4D flow, just to understand what's actually happening. So this patient had an aortic prosthesis, I think it was something similar to that. I mean, I've never seen how, of course, how that was implemented in the patient. They suspected that there is maybe a kink and some false lumen. The patient had some reoccurring strokes, and yeah, they just wanted to know what was actually going on. So we did this 40 flow scan, which was a 7-minute scan. It was like breathing navigation gated, so there was some correction on the breathing motion. This TR was 4 milliseconds. It was like a 2.5 millimeter isotopic resolution. We had 18 cardiac frames and a bank of 250 centimeter per second. And it was 2 times accelerated. So there are some acceleration methods that you can actually use to make it faster. So yeah, that was the scan we did. Overall, I think it took a bit longer. It was more like 10 plus minutes because this navigator did not perform so well. Yeah, and that was how the magnitude image looked after the scan. So typically in 40 flow scans, you have a very poor contrast between the blood and the surrounding tissue. That's typical. That's just the sequence itself. I just slightly indicated here where this protesis actually was. It was this region. Here you will have some artifacts because of the metal clamps the patient had in the chest. And I calculated this angiogram. So from this 40 flow data, you can also calculate pseudo angiograms, which are just the absolute value of the velocity. And already you saw in this angiogram that there is like some very high intense region, which was a high velocity jet, which was probably created because the protesis kind of made a kink here. So that's the original aorta, and then there was a kink up here. Yeah, so this is again the software I mentioned in the beginning. And you see here the overview. So it's like this all these 3 velocity encoded images, as we talked about earlier in this talk. So you have here, for example, the left-right motion, and which you see the jet already. Here you have the up and down motion encoded. So you see here the blood is going in this upward direction, and here it's going downward. And that encoding is the in-plane, out-of-plane motion. So you don't see much going on here right now. So if you combine all these and you do, you plot here, I think I plotted just the velocity vector. You see that there is overall medium velocities at systole, but there is like a very high velocity jet in systole up here that you can already recognize. So if you do a segmentation of the aorta, that's what you see here. I've also drawn some RIs at certain positions, so just in the original aorta, but also in the prosthetic part here, and also just at this kink. And yeah, here in this zoomed image, you see this jet a little bit better that is happening. And you see here, and that is especially the region that the clinicians were interested in, you see a vortex formation of like very low velocity, low velocity region, which probably caused some plaque formation or some, just some clotting formation within that region, which is why the patient got reoccurring strokes. Yeah, you can analyze the velocity at these different positions in this software. Sometimes you have to do some corrections. So this was, for example, the average velocity for each of these RIs. This was the through plane maximum velocity. And you saw here in this kind of orange one that we kind of had actually one of these aliasing artifacts, which I didn't mention here, but this was something incorrect. We have the net flow. Yeah, so that's basically what you can get out of the velocity values. And we saw that that the jet here, just at this kink, had maximum velocities of 140 centimeter per second. Just just behind it, so just right here, the maximum velocities were much higher. So it always depends a bit like how accurate that was. And we saw here that in these regions after the kink, excluding this jet region, there were like very low maximum velocities, indicating there is just just slow flowing blood circulating all over again. And here is just some like screenshots of systole and diastole. So you see in systole there is a jet, and in diastole you have this vortex formation. Yeah, I'm not sure if it's a false lumen or not. I mean, that's something I cannot really tell. Here is a time resolved video of this. So you see, so you see the jet and then kind of this vortex formation, which will influence, of course, also the filling of the carotid arteries. And that's like, yeah, I'm not sure if my computer is handling this now well. This is, of course, the image was much larger, so actually we could see very well down also the aorta and not just this upper part, which I think is interesting. But yeah, unfortunately, I don't know what exactly happened to this patient. I just provided this information. I don't know like what decision was made or what like the conclusion was from the clinicians about this information. It's just like, it was not like a typical situation that they did this scan on that patient. It was really just an exception because they did not know exactly what to do. So that's a bit unfortunate. Yeah, but that's it for now. If you have any questions, you can let me know, and we can also discuss some more topics that you might be interested in.
Thank you very much, Eva. I wasn't very familiar with the topic myself, but I feel like now I have a clear understanding of the basics. And yes, Eva said, if anyone has any questions, feel free to either raise your hands and I can allow you to talk, or write your question in the chat. In the meantime, I have a question myself. Since you said for this specific patient, they asked you to do 4D flow after doing an ultrasound. Does that mean that 4D flow is not standard in the clinics?
No, it's not. Yeah, I mean, I don't know what, let's say, the current status quo is, but it usually is not like the gold standard in the clinic. I don't know even how many people have this type of sequences like properly installed. I know that, for example, I worked with Philips scanners on these images and for a long time. And there it was just available, so you could just do a 4D flow scan. But I realized that, for example, with Siemens scanners, I think you would have to have a certain sequence installed that does 4D flow. So I have not done 4D flow now on Siemens scanners, to be honest. And the problem is also a little bit, it's easy to scan because you just basically put that volume on top of your region of interest. You don't have to do like complex angulations or whatever. But then again, it's complex to analyze in the end. I mean, you see like from this example, it really requires like some analysis and some planning and reorientation. And then it's very long. So there has been acceleration techniques, and I've worked on this myself, but then you always accelerate the scan at the cost of something. So for example, you could also accelerate the scan by just making the spatial resolution a bit larger, or you could accelerate the scan by making your temporal resolution a bit lower. But by that, you will already like average a little bit your velocity. And by averaging your velocity, you might, for example, lose your peak velocity value, your like maximum peak velocity that many doctors are very much interested in when it, for example, comes to aortic stenosis patients, because they want that peak velocity in order to make decisions on on like surgery or not. So I think in that sense, I think it's still a little bit up to I don't know, the vendors or the researchers to get like a very stable, robust, fast sequence that gives us all this information.
There's a question in the chat from Abdi. Can you see it?
1 second. Yeah, I'm not sure if I see. Sorry,
He's asking what the efficiency of 4D flow is after the CMR under stress.
What the efficiency of flow is. 1 second, I have to read the question. I think I have to chat here. So you mean like if it's with efficiency, you mean like the scan efficiency, like how long it takes, or how the 4D flow looks under stress performance? So what you can, you can just like scan, of course, under stress. That's fine. I mean, that works just the same way. In the end, your scan will probably even be a bit shorter because you have a lower heart rate and you have less, let's say, diastolic parts in your image, which you're not so much interested in. But it should perform the same way, nevertheless. So I'm not sure if that answers your question, or otherwise you can also retype it and I can answer the next question if it didn't answer your question. Do you encounter susceptibility artifacts? Yeah, that's actually actually that's of course a problem. I mean, there is of course regions in which you don't have signal at all. That is, if you like here, what you see here. So if you have, of course, some metal clamps, that's a problem. But that's more a problem when you have a valve replacement. It's really hard to actually measure the flow if there is susceptibility artifacts around it by this prosthetic valve, for example. And of course, like any kind of susceptibility effect that will be also a bit further from this valve, it will just kind of affect your velocity estimation. Yeah, that is definitely a problem. I think that's really hard to solve.
And one more question. Since you talked about the spatial resolution, since I'm low field MRI side of things, is there a specific magnetic field strength required to do a 4D flow?
Well, you can do it. I did it also on 70 ones. It was actually quite straightforward. I think the problem is really the SNR problem, right? Like at low field, it's also possible, but you just have to compensate for the loss of SNR. I mean, I also did like low field flow scans, and it was also possible. If you have less SNR, so less signal, that makes your phase noisier in turn. So your velocity estimation will be noisier or less accurate. And that is, of course, a problem. If you have, yeah, you can compensate for it like you can in any sequence. So you can again choose like a larger voxel size, for example, but it will lead to the problems I also mentioned earlier. Larger voxel size will then not solve this problem. But yeah, in general, it is actually very well possible at many different field strengths, especially because you're looking at, let's say, a phase difference image always. I mean, that makes it a long scan, but this phase difference will correct already for a lot of phase effects that you might encounter due to, some, I don't know, inhomogeneities or whatsoever. So it's a nice thing, yeah.
There's one more question from Adewale in the question and answer section.
I just see the susceptibility artifact.
It's in the, there's a separate Q&A chat.
So maybe you can read it out before I find
Yes.
it.
He says, aside the aorta, what other body part can we apply 40 flow sequence to?
Oh yeah, that's a good question. We can actually apply it to any artery. So you can do it in the carotid arteries. You can also apply it to the brain. So in the circle of Willis, you can femoral arteries. You can even to like the coronary arteries. Although this is like really, really challenging due to the motion of the heart. But there is no limit. You can also apply it to veins or like even like I think like cerebral fluid flow or something like people applied it to. You can also apply 40 flow to not only to encode for velocity of the moving blood, but you can also apply it for velocity. Let's say if you a colleague of mine did this, if you, for example, move your leg, right? Like the motion of your muscles or whatever. So it just encodes motion in the first place. So you can also use it to encode any other type of motion that you're interested in. But yeah, that's actually a good point. That's something I should have included. Yeah, there's of course, basically all vessels that you think of, you can apply that.
Well, I think if there's no further questions, we can finish the seminar here. The recording will be uploaded to YouTube as per usual. And and for the On Your Future mentorship attendees, we will move the check-in to later this month, in August, I know. But yeah, thank you very much, Eva, for your time. It was a good presentation.
Thank you. It is nice moderation. And I think I'll see you guys then next month for our seminar. Yeah.
Perfect. Thank you.